Good afternoon, everyone. Welcome to the elective session, Care Management Transformed, Innovative Strategies for Personalized Patient Care and Success and Access. My name is Christina Abraham, and I'll be the MC of today's session. I hold a master's degree in public health and have spent the majority of the last decade working with primary care practices just like yours across the state of New York, help prepare for and operationalize for VBC. I spent most of that time focused on Medicaid patients, so the conversation we're going to have today rings so true as we think about how to use our resources effectively and efficiently for our most vulnerable populations. I'm so glad to be here with you all today. Today, we're going to be diving into the aspects of personalized care management. We'll start with an overview of what identifying and risk stratifying patients looks like in PCF, and then I'll introduce you to your peer presenters. We'll hear about how they are risk stratifying patients and then save time for question and answers at the end of the session. Our goal today is to share different approaches to and aspects of personalized care management, like risk stratification, talk about lessons learned, and recognize the impact practices are seeing on patient outcomes and meeting model aims. Now let's take a moment to review key insights for our most recent care delivery reporting period in 2023. In PCF's Care Delivery Reporting Survey, we learned that 15% of practices use only a data-driven algorithm to risk stratify patients, while 80% of practices use both clinical intuition and a data-driven algorithm to risk stratify patients. These insights indicate a trend of using both algorithms and clinical intuition to drive risk stratification, which aligns with our topic of discussion today. So what does this mean for us? As we move forward, you will hear from Penn Primary Pottstown in Pennsylvania and Anschutz Internal Medicine in Colorado, who have utilized these strategies effectively. They have developed care management approaches which have lowered their AHU, and these examples will provide us with practical insights that may be tested in your respective practices. The ultimate goal here is not just to learn, but to apply these strategies and tactics in real-world scenarios for effective and patient-centric care delivery. We look forward to an engaging and informative discussion ahead. Thank you for your participation. Now I will turn it over to our speakers to introduce themselves and their practices. Nancy, maybe we can start with you and Theresa.
Okay. Hello, everyone. I'm Nancy Mclaughlin. I'm the director of Penn Partners in Care with the University of Pennsylvania, Penn Medicine. I'm a nurse by background and looking forward to our discussion today.
Good afternoon, everyone. My name is Theresa Walt, and I report to Nancy Mclaughlin within the Penn Partners in Care division within Penn Medicine, based out of Philadelphia, Pennsylvania. I am the lead supervisor for our care management program that houses the Penn Primary Care Pottstown location. I've been a nurse for 20 years. I will turn it back over to Christina.
All right. Dr. Lobo, do you want to introduce yourself and then pass it off to Kia?
Sure. Hello. My name is Ingrid Lobo. I'm an internist at the Anschutz Internal Medicine Clinic. I've been there about 15 years, and I recently stepped down as medical director in November after 4 years. Just to share a little bit about our clinic, the Anschutz Internal Medicine practice is the largest primary care practice associated with the university. We are in the Aurora/Denver area. We serve almost 17,000 patients and have over 60 providers. We see all kinds of complex patients, from transplant patients to just staff that potentially seek their primary care in our clinic. So again, a wide variety of patients, a large practice with many, many moving parts. I'll move it on to Kia.
Hi, my name is Kia Henderson. I'm the care coordinator at Anschutz Internal Medicine. I've been doing this role for almost a year. It'll be a year in June, actually. So it's right around the corner. And our presentation is actually about my role. So we're excited to show you what we've accomplished.
Awesome. Thanks, everyone. So in a moment, I'm going to pass it to Penn Primary to go through their approach to personalized care management. Nancy and Theresa, your practice's AHU has been constantly improving. And when we asked you in your practice what you all thought most contributed to your improvement in AHU. You highlighted aspects of your care management program. So I'm going to head over to your slides now, and we'll pass it off to both of you to walk through.
Thank you.
Thanks.
All right. Can you advance the slide to slide 6, please? All right. So I'm going to talk about the graph. Sorry about the slide. The slide deck is just a little out of order from the presenter mode. Our Penn Primary Care Pottstown office is one of many offices within our region. This office has exhibited true decrease in the AHU trend. As you can see, for the time period of Q2 of 2022 to Q2 of 2023, we've been able to decrease ED utilization in this office in particular by 29%. The office has been part of the PCF program since its start in 2021, right after a CPC Plus ended for us. And the current panel size for this office is right around 6,300 to 6,400 patients. We have 3 providers in that office, 3 internal medicine providers, 2 APPs, and 1 provider that's actually duly credentialed as a PCP and pulmonary specialist. Based upon the numbers that you're seeing on the screen, we're able to utilize reports from our payers and our ACO, where we've been involved with an ACO since 2017, to outreach to patients within 48 hours of their emergency room visit to schedule appropriate follow-up appointments. We share data with our providers at all of our locations, including the one that we're speaking of about today, which is imperative in changing the cycle for increased patient outcomes. Provider and staff education is also very imperative on current data in regards to if we're seeing a trend in increasing utilization and readmission rates. And we're also having the providers, it's really important for the providers to see the data and see these patients in the office and educate the patient on when and why to use the emergency room. We have unlimited access to our provider schedules, and they accommodate all of the patients into their schedules, which has been a very big key to our success. I will pass it to Nancy, who will go back to slide 6.
Okay, thanks, Theresa.
Sure.
So just to put this practice in perspective within the Penn's program, so we have a comprehensive care management program that actually covers 58 primary care practices within the physician network, primary care network. And Pottstown is just one of those practices. There's about over 400,000 patients in all of those practices, but the focus of our program is to focus on those patients that are high risk. So high risk, as we use a risk score within our EPIC system that we use to flag patients, but also those patients that are identified as high risk anecdotally, so we don't stay strict to the risk score, but we pretty much treat between 2.5% to 5% of our population that we consider high risk. We get patients identified, like Theresa said, through the payers, through our ACO, and also we get direct referrals. We get about 900 referrals a month to our program directly from our providers. The 2 main interventions that our program focuses on are the transitions of care. So really ensuring safe transitions after the emergency room and then after hospital stay. And the second one is our longitudinal care management program, where we really focus on improving patient management and of chronic disease. So really focusing on patients with uncontrolled disease and really making sure that their care is coordinated and they're given the right support to overcome social barriers that might impact their management of their disease, looking at medication adherence. We have a pharmacy team. So we really try to follow those patients over a period of time to impact overall management of their chronic disease and utilization. So with the main goals of decreasing utilization and decreasing the overall cost of care. We have on our team a full set of multidisciplinary team members. So we have nurses, social workers, pharmacists, care partners, which are unlicensed navigators, and we have pharmacy techs. And so we really work as a full group within Penn Partners to service the patients and put that full safety net around the patient in between visits and after their hospital stay. We also have partners, vendor partners for nutrition. We also have a behavioral health program, which is a collaborative care program that's embedded in our primary care practices called Penn Integrated Care. And then we also team up with our post-acute care managers and all of our community partners to really support our patients. And then really to try, like Theresa said, to continually improve, the management of our population. We try to share data and look at opportunities either at the very practice level or the patient level to improve those outcomes. And so I think what Theresa, mentioned about this one particular practice where we really have seen the drop in the utilization is that this practice is a relatively small practice with a nice group of providers with APPs and, MDs, that really having access for the patient has really helped to keep patients from overutilization, where we can get the patient in soon, that the providers are very flexible in adjusting schedules or taking on other patients that maybe they don't traditionally follow, and really trying to put the patient first and get them seen and get the right care at the right time. So that's really why this practice in particular, we have seen such an improved performance.
All right. I will take over on slide 7.
No, thanks.
Thank you, Nancy. So the Penn Primary Care Pottstown risk stratification approach, obviously, there's multiple factors that come into this. Obviously, clinical intuition, as Nancy elaborated on, we have our transition care management and emergency department usage reports that we look at. We have the providers, we have our post-acute care managers that work in the hospital setting that relay information to us, our post-acute social work team as well. The team that we're part of, the Penn Partners in Care team, and then obviously coordinated patient lists from all of our payers, in particular with, usage for hemoglobin A1C, hypertension, and payer related. Combining that with the data-driven algorithm, we focus on patients with a risk score greater than 6 to enroll them into our LCM program, but that does not eliminate any patient from our outreach attempts in regards to their transition care management or ED utilization. We call all patients regardless. Other data-driven algorithms include the uncontrolled chronic diseases, such as what you see on your screen, the congestive heart failure, the diabetes, and hypertension, to name a few. Really focusing on the high emergency utilization, trying to decrease that, bundled diagnosis, and obviously the payer identified high risk reports, patient listing reports that we get from our payers. Combining all of this from a risk stratification approach and developing the care management program, back in 2015, I was able to develop the care management program with only myself and another care manager at that time. Since then, we have grown our team to 4 care managers, 3 care partners, one social worker, and pharmacy support specifically for this office and our other offices in our region. Our practice leverages various sources of data, as previously mentioned. The practice targets patients with, as I stated, the UPH risk score greater than 6. And the clinical tuition is so vital to the identification of the patients. However, patients who have a low risk score, such as they went to the emergency room and they came out with an acute event, they really need us to wrap our arms around them as well. So we also take them into consideration and enroll them for future follow-up. We have a great non-licensed clinical staff, such as medical assistants, who are able to think and act quickly and escalate situations very quickly to our RN care managers, who expedite the care of the patient. We work very, very closely with all of our providers in all of our locations. But as Nancy alluded to, in this particular office, we have a team approach with and collaborating with the providers from a care management standpoint. I believe that's it for our slides. I'll pass it back to Christina.
Thanks so much, Nancy and Theresa, for that overview. And we'd like to hear from all the practices on the line today in the chat. How does your practice integrate health-related social needs screening data into your process for risk stratifying patients? Feel free to drop your comments in the chat. All right, so we're gonna just move along here. I'm gonna now pass it to Dr. Lobo and Kia to provide an overview of their program. And Dr. Lobo, feel free to divide up the slides here how you'd like, but we can start with either outcomes or kind of the overview.
Sure. I think we'll just start with this slide and go from there. So again, just to recap, Kia and I are from Anschutz Internal Medicine. We come from a large university-based internal medicine practice where we take care of over 17,000 patients. Again, a very complex patient population, lots of cancer patients, transplant patients, all payer mixes, and lots of providers, over 60 providers. We were lucky enough to be part of CPC Plus, and we were able to integrate all kinds of amazing services into our clinic. So when CPC Plus was started, we were able to have 2 care managers to do transitions of care after hospitalizations, and another care manager who basically followed our most complex patients. We got some social work support. We were able to get a pharmacist, a nutritionist, and some mental health support. So we were really, really, really lucky. In addition, we already have amazing nurses in our clinic, almost 10 nurses in our clinic, and about 20 MAs. Despite having these amazing services, we still were falling short on meeting our hypertension metrics, diabetes metrics, and really decreasing utilizations. We figured out that there was more that we needed to do. In addition to the CPC Plus services that we had in our clinic, we started to do piecemeal outreach in our clinic. So we would have a medical assistant do some outreach on patients who weren't meeting their diabetes metrics, or we'd say, oh, why don't you work with your provider and get some patients in there for their Medicare annuals. Again, but as we all know, it's really, really hard to do these piecemeal outreach in an already busy clinic, because if you're short staffed, the MAs are running around rooming patients, or the nurses are on the phone doing triage, and it's just chaos. So despite our efforts to get some outreach within our clinic, there was nothing that was really sustainable or we were able to do, and on a consistent basis, because drama and chaos would always happen in the clinic, especially with so many providers and so many patients coming in. Additionally, we have this amazing population health program that happens across all of our clinics. Again, there's many primary care clinics, and they would send out letters to patients who were needing their Medicare annuals, or letters for patients who might not be meeting their hypertension metrics or diabetes metrics. But again, this population health approach from the centralized level, in addition to what we were already doing in our clinic, was not enough. Providers were aware we weren't meeting our metrics, so we would oftentimes get lists every month to say, hey, you're not doing that great in your diabetes, or you're not doing that great in your hypertension metric. But we're all busy. There was no action point that we were actually taking to help us meet these metrics. So in response to this, we developed this care coordinator role. And the idea of the care coordinator role was really population health for our clinic that had some protocols that could really do a few things. Number one, identify patients who weren't meeting chronic disease metrics, or weren't meeting their annuals, or who weren't being seen. And then number two, having protocols in place to get them into the clinic or get them in to see a nurse or figure out what the barrier was for why they're not getting their care. And then number 3, engage these amazing wraparound services that we got through CPC Plus and really coordinate care and utilize all of these services that we have to really do centralized patient care. So the care coordinator, we started about a year ago, and she identifies patients not meeting certain care gaps. The first is Medicare annuals. So patients who aren't meeting that, who haven't been seen in over a year. The second is diabetes care. The third is hypertension. And the fourth is just panel cleanup. Are patients really seen in our clinic anymore? Did they potentially transfer care from a different insurance provider? Data is everything. If our data isn't correct, then all of the endpoints that the data reports are shooting out have no meaning. So we have to make sure that our panel assessments are correct. So we developed this role, and this was really our focus, was on some really identifying patients who weren't meeting their needs and then figuring out how to problem solve. Kia, do you want to kind of talk a little bit about some of what you actually did a little bit more in detail?
Yeah, of course. So I'll start with, well, for all of the criteria, I run a bi-monthly report for all of the providers just so none of their patients are falling through the cracks. I'll start with diabetes because it's honestly my easiest panel to start with. So once I run the report, I check for any diabetic patients that haven't had an A1C checked in a year, and then as well as for those patients that have an A1C of 8 or higher, I want to get those patients in for a 3-month follow-up. Once I get those patients scheduled, I pin labs for the provider, typically a lipid panel, a comprehensive or basic metabolic panel, A1C, and urine microalbumin. So I'll pin those over for the provider to sign. Once they're signed, I notify the patient so they can get those labs completed prior to their appointment. That way they can discuss the results with the provider. And then for the Medicare annuals, same thing applies. I run the report and see if they are due for any annuals, usually the year and a day from their previous. There were also quite a few patients that had not had Medicare annuals, so I got quite a few scheduled for their first Medicare annual. I pinned it labs for them as well as any diagnostic testing they were due for. So any mammograms, colonoscopies, they were able to get those scheduled and or completed prior to their visits as well. And then for our biggest beast to conquer, which was hypertension, once I ran that report, it's a constantly moving variable. So for those patients, the report would flag any patients that had a blood pressure that was 140, greater than or equal to 140/90. And this was not just in our clinic, this would be in any ambulatory care visit in our institution. So let's say they were seen in ortho and they had a higher reading, I would be notified through the report that they needed to be seen. So for our hypertensive patients, we give them quite a few options. They can come in for an in-person visit, which would entail them bringing in their own personal cuffs so we can validate those for accuracy. We have staff members that would check their blood pressure with the in-clinic cuffs as well as their personal cuffs to make sure they're accurate. If they're still in a hypertensive state, we will want them to get on the schedule to see their primary care physician for further evaluation. Another option would be for me to give them a call to see. A lot of times they don't want to come in due to parking or any type of issues of that. They have the option, if their cuff is on validatebp.org, their cuff has already been validated, so they can actually give me an at-home reading over the phone. And then there have been some instances where I've called the patient and they're out and about, they have their own cuff, it's been validated, but we clearly can't get a blood pressure reading because they're not at home. So we can also schedule them for virtual visits with a staff member to check their readings as well. So we have quite a few options for them with the blood pressure readings. Um, and then we also have, like Dr. Lobo mentioned, a lot of great resources, care management resources for our population health team. So we do have a nutritionist, two pharmacists, a social worker, about 10 nurses, and two care managers to assist me with further barriers the patients may be experiencing. Just to give a couple examples, if the patient's diabetic and they're experiencing issues with their diet, I can get them scheduled with the nutritionist. If they're having any issues with titration, I can get them assistance with pharmacy, as well as we just recently started a program for patients that don't have their own blood pressure cuffs. We actually can loan them out through our pharmacy to take those home and keep track of their reading and get some assistance with pharmacy as well. And then on the personalized barriers that I noticed as I was running these reports, we were running into quite a few patients that were not able to communicate with the institution to get scheduled for appointments or to get refills because of a language barrier. Usually when you call into a facility or institution, you have two options of either English or Spanish. Uh, and we have a very diverse group of patients. And we had, for example, some Korean patients that couldn't get refills or appointments scheduled. And I'm able to break that barrier by calling them with the interpreter on the other line. And they're able to let me know what they may need, whether that's an appointment or a refill. Another barrier that they were experiencing was transportation issues. Either the patient or their spouse were no longer driving and they had no idea how they could get to an appointment. I'm able to utilize my social work team to help me get that transportation need met, as well as if they happen to lose their insurance, she's able to assist them with the getting that insurance um, assistance as well. Um, Aside from the patients having barriers, I noticed that the institution itself was experiencing barriers. Like Dr. Lobo mentioned, there were patients that were deceased and their charts had not been marked as such. So I was able to notify the health management team just to update those charts. There were also patients that had relocated outside of Colorado or had established care elsewhere, and they were still affecting our metrics. So I was able to update their charts in that capacity. And then one of the final things that I did notice was when I was speaking to these patients, they would say, no, I've already had these mammograms completed or colonoscopies, and they would tell me where they were done. So I was able to reach out to those outside facilities to get those records sent to us so that I could close those care gaps and show that they have been met. So yeah, those are basically what I have been doing overall. Um, the reason this position has been so impactful to me is I'm able to see those benefits and the services I'm providing to a diverse and marginalized community that weren't receiving these resources prior to my position. So I do want to thank you, Dr. Lobo, for even creating this role. It's not often that we get an opportunity to pat ourselves on the back. But we're going to do that now and looking at our data. And we have proved that only in a year's time that we have made a substantial improvement in patient care and health navigation.
Perfect. Thank you, Christina. As Kia mentioned, this has been a success. As you can see, we have increased our or improved all of our metrics. So our A1Cs have improved from 71% to 74% for hemoglobin A1Cs less than 8. For patients actually coming in and getting their A1Cs checked, we went from 88% to 93%. So again, we were doing fairly well with our diabetes metrics, but now we're even doing better. we are definitely getting Medicare annual scheduled. We were at 57% and now 66% and even higher to date. And again, our blood pressure control, which has been the hardest, went from 65% to 70%. I do want to comment just briefly. I think that the end game is, of course, taking really, really amazing care of our patients and hopefully having them utilize the healthcare system in a way that makes sense for them. And I think that, we want to decrease utilization and ER visits and hospitalizations. And I think what we found over the last several years is that as we improve diabetes care, as we improve hypertension, as we get patients in for their annuals, as we get them more comfortable interacting with their clinic and their medical home, they don't go to the ER as much. They don't go to the hospital as much because we're really wrapping our arms around them. And so although this doesn't show this is kind of what we've empirically just found. Additionally, the second thing, as a provider in the clinic that I love about having Kia is I'm not looking at my metrics. I'm not looking at all of these quality metrics every month and saying, oh gosh, how am I doing on my blood pressure? How are my patients with diabetes doing? I know Kia's monitoring this for me, checking in with patients, getting them scheduled with me. And there's somebody outside of me actually managing these patients who aren't meeting their metrics and helping me get them in the clinic and helping me help these patients with this kind of robust population health team. So I think this was kind of something that we really, really wanted for the clinic. And although it's been so amazing to see the progression of, again, getting the population health services, having this amazing, centralized population health team, and then now this kind of final bit of this really personalized patient care in our clinic. It's been really wonderful to see, and wonderful to see our patients get this amazing care. Christina, I think we're set over here now.
Thank you so much, Dr. Lobo, Kia. It's really wonderful to hear the overview that you both just provided, and especially Kia, as you kind of described the specific tactics of your role. I think it was super informative and helpful. So thank you so much. We're gonna go on to our question and answer session. So we encourage everyone to send their questions in the chat following the presentations of our featured speakers here. So feel free to send your thoughts, comments, questions as we go along here. But for our first question, I'm going to pass it to you, Nancy. Can you talk a little bit about the automated SDOH assessments that you all are conducting?
Yeah, so at the beginning of our program, we had, a couple of social workers, which we've, added as we've, developed the program. But we were doing, manual assessments when we had some interaction or a consult for the patient. And we felt that was not really capturing the full set of social needs that might have been in our population. So about a year and a half ago, we implemented an automated, it was a part of their pre-visit questionnaire that they get before they come to the practice. They get to complete their social assessment. So that is ready for the provider when the patient comes in, and then they can initiate a referral to our team. Or the patient can even self-service based on the findings of that assessment. They can self-service to our social determinants link that we have called Find Help, where they can actually self-service for resources. So we've seen a really big uptake on the patient use of that service. So in addition to our social workers, we have the ability for patients to access resources on their own. So we're really excited about the work we've done there.
Awesome. All right, next question. Theresa, are the care managers embedded, off-site, home-based, or a mix?
We have a hybrid model. So in particular for this practice, we have a care manager that is hybrid. She goes in quite frequently, if not two times a week. if not more, depending on when she needs to meet with patients directly or how many referrals she's getting from the provider. So it is a hybrid model, and that is the model that we've implemented for all of our practices.
And this is a question for the group, so feel free to jump in as you have thoughts. But can you talk a little bit about how providers are able to accommodate, the volume of patients being added to their schedule, and how to sort of address any feelings of being overwhelmed or burnout with regard to the care management program?
I can take it from the Penn Primary Care Pottstown standpoint. It's a work in progress. We have developed these working relationships with these providers and the office manager, and all of the providers have kind of bought in to the concept of needing to see these patients, decreasing utilization, enrolling in care management. So they've built practice slots into their schedules for us to use for either same day or post-hospital visits, which is the EDs or the TCMs. So having those slots built into the schedule for us to use really accommodates these patients. And as Nancy said, we have providers that are willing to see each other's patients. If a provider is on PTO, then the other person will pick up. So it's really, all of those little variables coming together to benefit the patient.
Dr. Lobo, any thoughts there?
I think providers are happy to know about the patients that need help. I'm in agreement with Theresa. I think that we all have buy-in once we know that there's an issue. Once a patient's here with us or we're aware of something, we can get them in and then, get social work involved, care managers involved, get the pharmacist involved. If we get the way I think about it is if I see a patient and I'm like, okay, I'm going to have a 3-month follow-up, all those touches in between through the population health team are fantastic for the patient. So I might see a patient in January, do a diabetes follow-up in April, but the nutritionist has met with the patient twice. The pharmacist has met with the patient, weekly to titrate up the insulin. And, Kia has followed up to be like, hey, you missed that appointment. Like, why did you, so there's so many people that are touching and keeping an eye on the patient. I think that's what makes it more of a partnership. And so it doesn't feel like it's all on the PCP. So I would think that if it was just a PC, like the old model where it would just be a PCP, an MA, and a nurse, and then all of that work still on you without some of the services involved to help, that might feel daunting. But if you have some of these services to help, then I think it's a little bit more manageable.
Yeah, really that team-based care and operating as a team for every patient. I'm going to combine a couple of the questions that we're getting in the Q&A for both practices, so feel free to, again, just jump in. Can you each talk about how large your patient panels are? And I know both practices have sort of different methods of identifying their panels for the care management population. So if you could just talk about the size of the panel and kind of how you've addressed handling that volume.
Well, do you want me to take it first? Or? Yeah. So like the practice that we're talking about is one of our smaller practices. I think, what do we have? About 6,000 patients on the panel. So we try to engage, like I said, 2 to 5% of that population in our longitudinal care management program. It is it is difficult sometimes to balance provider referrals with those recommended by the payers. So we really try to, prioritize the patients based on those risk factors so that we can, get to the higher risk patients first.
And then I would say at Anschutz, the provider panels are based on how much you're in clinic. So of the 17,000 patients, if you're in clinic a lot more, a provider might have 700 to 1,500 patients, and a provider who's only here 2 half days because they, run the med school or something like that, then they might have a panel of 80. I think Kia's position is really across our entire clinic. So she really manages all of our panels and those not meeting their metrics. So her position is a little bit different. But to Nancy's point, our care managers and our social workers do longitudinal care management for our most complex patients. And again, those hospital discharges and those with really high social needs. But what we found is that there are a sector of patients who are very, very, very high risk. And we have a ton of resources that we, making sure social workers talking to them about transportation, making sure the care managers are saying, please call me first, don't call the central line. Like, we'll get you in the clinic instead of the ER. But despite our best efforts, that sometimes they continue to be high utilizers. So what we found is that Kia's position helps that kind of middle tier of patients not get to that high risk tier. So we're really preventing preventing that. So they really do understand how to access the clinic. We can prevent them from losing that limb. So they're not then having walking, things like that. So it's kind of combining the traditional care management program where you do the longitudinal care managers, you focus on the high risk and you focus on those who are the most complex. And this portion that Kia is doing, which is all of our population, get them in for their annual, and then we can preventively figure out what they're going to need to prevent the drama in the future. So kind of we do a little bit of Nancy and Theresa's approach, but a little bit something different. Kind of what I like to think of Kia is population health on steroids for the clinic.
Yeah, and I will point out too that we have a separate because we're so big, we have a separate pop health team that does a lot of the work that Kia does. So we do have similar efforts going on in our practices. So just a different team altogether.
Great. And then this is actually specifically to a comment that you made, Nancy, but can you talk a little bit about what the team's perception is of how health-related social needs are addressed given self-service, the auto referrals that you were referring to with Find Help?
Yeah, it's hard for us to really assess the impact of the self-service except by how many patients actually use it and what we can see what types of resources they're actually searching. But we can't tell really, did the patient connect with those resources? Did they make use of those resources? So, we still have our referral pattern. A lot of those patients, we have a system with patients with food insecurity get directed to a social worker for a call. So we're trying, because we can't address every need. So in addition to all the referrals we get from our providers, we do have a subset of those automated referrals that go to a social work team.
Great. And also for Penn Primary Care, what data warehouse are you using?
Not sure what they mean by a warehouse, but we have
to answer that one.
I'm not sure what that means, but we have internally, we have a lot of data we use in Tableau, which we're now in the process of moving to a Power BI dashboard. So we have multiple dashboards that we monitor a lot of the quality metrics that Kia is managing, the care gap closure, our transition work, our LCM work, our utilization. So we have dashboards that we use. And then, of course, we have some ACO arrangements, so we get data from them as well. So it comes from a lot of variety of sources. And, of course, we have a lot of data right in Epic in our analytics dash.
So kind of multiple sources feeding into the dashboards that you use every day. Got it. Last question I'm going to throw to this group as a whole, as we just have a couple of minutes left here. But from both practices, what advice would you give to the practices on the line who are looking to implement some of the strategies you've described here, or looking to kind of integrate some of the tactical pieces that have been discussed? Dr. Lobo, we can start with you.
Sure. For the practices that might not have the resources to hire someone like Kia, which is, again, kind of population health that is really just focused on the clinic population. So we can really, I think that there's so much that only data can provide as far as like pulling things in Epic, pulling, like looking at a dashboard, seeing where your metric is. really then figuring out like why the gap remains and really personalizing it, I think, is the key to Kia, is like really figuring out like, okay, why is that patient not getting that colonoscopy? Why is that patient's blood pressure still high? Really individualizing. I would say that it's going to, for most practices, it's going to be hard to have a full-time person do what Kia does on one practice level. And what I would say is that you can create processes in a clinic that are dispersed between 5 or 6 people, but with the same types of protocols. So my thought would be, you have this ideal role and then you piecemeal it out and make that person own that. Like, you're the Medicare annual like guru in the clinic. You're going to figure out like these 3 parts of hypertension and go from there. And again, I'm saying it like it's like super easy because like, hypertension took us 3 years to figure out. I mean, these are hard things, but I would say if you tackle it in small pieces, then when you are in a position, either your institution or Medicare or whomever is able to provide the resources to hire a person like Kia, then you have the protocols in place and you can put it into one person. But I would say start small, start with different people in the clinic being like the champion of different parts of these protocols.
That's great. Nancy, Theresa, any final thoughts for our Q&A session?
I agree with Dr. Lobo. You have to start small, little bits. If you don't have embedded care management, start with one person. And that could be like a non-licensed or a licensed role, and just start making those connections with those patients. Once they have someone that they can rely on, that person's going to advocate for that patient. So, just start small, and it's a work in progress for sure.
Awesome. Well, thank you so much to all of you. If we can just bring back up the slides so we can share our resources. That brings us to the end of this session on care management. Again, thank you so much to all our speakers. Such an enlightening discussion. And to all our attendees, thank you for your active participation and all the questions you raised. And I know there were some questions that we did not get to in the chat, so would encourage you all to connect and continue the conversation. So we have the additional resources, the poster walk that's going to be happening following this call, and we encourage you to review the materials that are up here to further deepen your knowledge and understanding. After this, you're invited to participate in, like I said, the poster talk, the small group networking discussions that will provide sort of a deep dive into these posters that were reviewed yesterday. And in this session, peers and poster authors will be available to discuss the findings and the insights here. And then we'll have James Lee and Katie Schultz of the PCF model team, who will lead our closing on gratitude and growth, a closing note on our journey together. Thank you so much for your time and your active involvement in today's session, and we will see you all soon. Thank you.